Sorry for the technical glitch. So we'll show the two cases. The first case is very simple case, refer with the drop nucleus for vitrectomy and secondary IOL. We always think in the simple case, we start the case and yeah, so we can just see the nucleus, and as the plan we will start the surgery. Plan for center, the nucleus was in. So at the beginning it was very simple. After going inside, we found that there's a RD also, and along with the RD we can see some nucleus fragment which has gone subretinally. From suddenly it has become a long case and it was never ending. So we did ILM pilling under PFCL, and still lots of matter we can see. Did a retinotomy to remove the larger piece, and smaller piece was very difficult even with the help of PFCL to remove it. So it was followed by the secondary IOL, and end result was good. The second case is, as you say, the sleepless night. So we had a one PDR case with TRD and FVP. So we have planned this case that this will require a long time, and the total macula was covered with the membrane. Anti-VEGF was given 2 days before. As we have started vitrectomy from periphery, we can see there is lots of focal attachments. And it's a very difficult with the help of only cutter to remove each and every attachments, and we are trying to prevent the iatrogenic breaks. We can see that the retina is very ischemic, so any manipulation can lead to more breaks, which we don't want in at least diabetic cases. This time we have planned to shift to a bimanual. Anything, if you just try to do the PVD or just try to give any traction, and because of lots of focal attachments, there's a very fear of getting things.
Is it the same looping it
I
is
think
going on?
no, it's just
Because yes, this one. No, no, no.
so see here
The
we
previous
can
one.
here then we shifted to a bimanual surgery, and we try to meticulously cut and remove all the attachments and prevent the breaks on the retina, especially in the macular areas. And we can use the cutter tip in between, or there is a proportional hydro dissection we can do to just find the exact plane of dissection in such cases. And these cases really require lots of patience, but finally able to remove the full membrane. But there are still few attachments. We're able to cut with in between the attachment with help of cutters. And at the end, we're able to laser it and able to settle the retina very well. Sure. Thank you. Thank you very much.
Thank you, Dr. Dharmesh. Usually, in all diabetic retinopathies, they are not like simple. They sometimes you think in ultrasonography we can't detect this membranous proliferation, flat TRDs. Now during the surgery, you will see a lot of attachments, multiple focal adhesions. So, any comments from Dr. Maiti?
Yeah, Dr. Borrell, do you think this kind of cases needs to be done ILM peeling? Because in Dharmesh case also, there was a little bit of puckering underneath the tractional retinal detachment, the fibroscopal proliferation.
Yes, if I see there is the macula is quite boggy on table because preoperatively OCT in many times it is not possible because of hemorrhage of media headiness or cataract. So in these cases, ILM peeling would be beneficial after removal of all the membranes. Dr. Atul?
Boral sir, I have found that the chances of tear is much more if we'll pull the membrane from the forceps towards the center of the vitreous cavity. If we'll keep over the surface of the retina, the chances, the pulling force will not be there. We have to just support the membrane over the surface of the retina, and then from the scissor we can cut the attachments.
So just to visualize, because it was so many multiple
No,
attachments.
that's what I'm saying.
visualize
If you are pulling the flap like this, you will pull the flap. If you keep the flap over the surface of the retina, the pulling force will not be there. We have to just keep it over the retina, and then we have to cut all the attachments. And one question I want to ask from Boral sir: at what IOP usually you are doing the surgery? Diabetic
35 to
surgery.
40.
40 surgery.
35 to 40, not more than 40, usually. But if there is a bleeding tendency, like a lot of oozing, but still I have to complete my procedure, then I am going above 40. 40 to 50, 55 maximum.
Okay. From the last 2.5 years, sir, I'm doing the surgery at around 15-20 IOP.
Okay.
And bleeding point I am cauterized, and I have found myself no study at this
Low
time.
IOP surgery.
The disc status is very well maintained
Yes.
even after 2 or 3 years.
You have to
with the low
always
IOP
like
surgeries.
yes.
We-
That's
we-
why you should not keep your IOP more than 40.
Yes.
That is otherwise you don't know the whatever your length of time the disc is becoming compromised.
So we can do between 25 to 30 and make it
Yes.
60 with the foot switch for just temporarily. But as you very correctly say, cauterizing also help a lot, and keeping 60 will be more damaging on the
Dr. Raja, what
nerves,
is your preferred choice of IOP?
diabetic vitrectomy.
Yes.
I usually keep at 25 my surgery. If there is a bleeding, I raise it to 60 temporarily. But most of my surgery is at 25 with
25.
right camera.
Yes. Dr. Devdulal? IOP?
Around 30, 25 to 30. One other thing I think helps really in diabetics is that with the 10,000 cutters we generally are more inclined to do a unimanual surgery. I mean, like with
Yes.
the right hand or the active hand. But when I see a membrane like this, I usually go in bi-manually. Put in a chandelier. It cuts the surgical time by half, and there's absolutely no, very minimal chance of creating a break. So you can get away with gas in most cases, most situations, and bad-looking membranes also do really, really well.
I think
Dr.
the main
Shantanu?
problem is to identify the plane, so which at times I think this proportional reflux do help.
Yeah, but the newer bevel cutter of 25 gauge and
Yeah, but
27
you
gauge
need
with,
to locate the plane
then-
first.
then, so that proportional reflux and the bevel cutter is really helpful. in
Dr.
such surgery.
Shantanu?
It needs patience, nothing else. In these cases, you have to be patient.